be talking about the hypercoagulable state. There are two pieces of this hypercoagulable state. One is hyperviscosity, and the other is the coagulation pathway. First, the coagulation pathway. As you know, there's an extrinsic and an intrinsic part of the pathway, mediated by factors that are numbered. 7 on the extrinsic pathway side, 12, 11, and 9 on the intrinsic pathway. They meet at a final common pathway. The final common pathway is mediated by 10 and 5. That leads to a series of activation events where the factors go from 5 to 5A, 10 to 10A, and the activation converts the prothrombin to the thrombin, then fibrin, fibrinogen, and finally the platelet thrombin fibrin complex that allows us to have a clot to seal the bleeding. The reason an ophthalmologist needs to know this is when we encounter stroke in a young person, arterial occlusion, or vein occlusion in a young person, venous sinus thrombosis, then one of the possible causes is that you are harboring a hypercoagulable state, that you have too much coagulation. And so now we're just going to go through what are the things that we need to know as ophthalmologists when we're encountering a patient, for example, who's a young patient who has a central retinal vein occlusion. We can have problems with mutations. The mutations can occur at the factor 5, and the most common is the factor 5 Leiden mutation. You can be heterozygote or homozygote for this mutation, and it leads to activated protein C resistance. Or you can have a mutation in the prothrombin gene, a single nucleotide polymorphism, A to G, at position 20210. So these are the two most common mutations that we see. There's a third mutation that is related to an independent graded risk factor for thrombosis called homocysteine. Homocysteine is converted to methionine, and so homocysteine is kind of like a bad guy and methionine is a good guy. This is a folate-dependent pathway mediated by an enzyme, methylene tetrahydrofolate reductase. Genetic mutations in the methylene tetrahydrofolate reductase at positions 6, 6, 5, and 1286 can lead to increases in homocysteine that is a graded risk factor for thrombosis. So those are the mutations. We can also have deficiency states in the cofactors that allow the clot to be broken down. Those cofactors are protein C and protein S. So if you have too little of protein C or protein S, you'll get a clot. Or the anti-thrombin 3, which is against the thrombin. So the deficiency states, anti-thrombin 3, protein C, protein S. In addition, we can have excess of one of the factors, 8. So if we have too much 8, or too little protein C, protein S, or anti-thrombin 3, or if we have mutations in the prothrombin gene or the factor 5 gene, these all lead to a hypercoagulable state. The other mechanism of getting a blood clot, though, is not from the coagulation pathway, but from hyperviscosity. Too much cell, not enough liquid. So in our blood, we can have too many red cells, polycythemia. We can have too many white cells, leukemia, leukocytosis. We can have too many platelets, essential thrombocythemia, thrombocytosis. We can have too much protein. We're not like proteins like albumin, but immunoglobulins. Those can be macroglobulins, like the lymphoproliferative disorder, Waldenstrom's macroglobulinemia, or immunoglobulins that attack the endothelium and the protein and the platelet membrane, leading to a platelet thrombin thrombosis. Those antibodies are against the phospholipid, antiphospholipid antibody, lupus anticoagulant. And we have functional assays to detect the lupus anticoagulant and the anti-cardiolipin antibodies. In our hospital, it's the dilute Russell venom vipertine, and we're going to do the PT and PTT. Most places, it's all bundled together, so you get all of this. and the endothelial target, the glycoprotein 2B antibody. So these are the antiphospholipid testing. You don't have to have lupus to have the lupus anticoagulant. So on the hyperviscosity side, we're going to be doing CBC and serum protein electrophoresis and testing for the lupus anticoagulant. So in any patient who has a thrombosis and is young, think about the hypercoagulable state, the coagulation pathway, and hyperviscosity, deficiencies, excesses, and mutations.